Okay, good evening everyone. Welcome to the Department of General Practice and Rural Health. Before we introduce our speakers, just so we don't forget, Alan would like to make an announcement.
I just wanted to take the chance to put a wee plug in for the Rapid Response Service. I'm not sure how many have used it or are aware of it. I've used it a fair bit recently, so they asked me to champion their cause. So if you don't know about the Rapid Response Service, I'll leave, this is a bunch of the guidelines and the criteria out on the desk. Essentially, well, who is aware of the Rapid Response Service? So a few of you aren't. Essentially, it's a way to kind of avoid some of those social admissions to some extent. Situations where people haven't got anything too major, maybe a UTI, they've had a fall or something, but it's just those fragile patients we have, the elderly, who are a bit borderline, and it doesn't take too much to tip them over the edge that they're not going to cope, and it's about avoiding admissions that otherwise, if they get a few things put in place, can stay in their own home. So essentially it's a same day service. It is only Monday to Friday, 9 to 5 sort of service, but they are pretty much very good at, a nurse comes and sees the patient, all it takes is a phone call from us, does a quick assessment, and a very thorough assessment, and puts the sort of supports in place that otherwise we have to jump through hoops and take ages and ages to get all set up through the NASC assessment and all that side of things, and they can get them going pretty much that day or the next day. And I've used it quite a number of times. It works very well and very helpful, so that's my plug for the Rapid Response Service.
And it's free, isn't it?
Thank you.
Thank you.
Thanks, Alan.
Right, so just a quick, very brief introduction of our speakers. Today our topic is allergy. We thought, being September, this was a good time of the year to schedule this. So we've got Anna Gilmour, well known here as a Dunedin GP, Musselburgh Medical Centre, also has an interest in allergy, obviously, and Anna has recently completed a qualification in allergy, which doubtless you'll tell us more about. Also, thanks to our other speaker, Josephine Greer, who's a full-time private practice dietitian here in Dunedin. So thanks so much for coming along tonight to talk to us about this.
No worries. Thanks for asking us. So as Peter said, I'm Anna Gilmour, for those who don't know me, and I'm a GP partner at Musselburgh Medical Centre, and I've been a GP for about 13 years. So I've just completed the Certificate of Allergic Diseases through the University of Western Sydney. I haven't quite received my certificate because graduation won't be till the end of the year, but I have done all the requirements. So that's a two-year program. The first year is theory and audio conferences and a 3-hour written exam at the end of the year, which was a bit of a shock to my system. But it was a great 3 hours of peace and quiet. I can highly recommend it. You're not allowed your cell phone or any interruptions. It was fantastic. A lot of money to pay for that. But and then this year has been clinical. So I've had to do 50 clinical hours with immunologists and allergists around the country that the university were happy with me to work with. So happy for me to work with. So I've just finished all that time, and I've just come back last week. All week was the ASCIA conference, the Australasian College, Australasian, it's terrible, Society for Immunology and Allergy, something, I forget what the C is. Anyway, and that was conference in Auckland all week, so lots of learning to be had. That qualification is the only qualification in allergy in the Southern Hemisphere, so if anybody's interested, I'm happy to talk more about it. There is another one through the Imperial College in London as well, and they're the only two I know of. And the reason I decided to study a bit more about allergy was it was an area of interest for me anyway, but I also could see that in our community there's a bit of a shortfall, and so I felt that I wanted to increase my knowledge and skills in this area, and hopefully be able to provide that for my own patients, but also for others who may require it. And in the DHB, in Southern DHB in particular, there's no clinical immunologists in Dunedin. And the nearest one we have is in Christchurch, which is Dr. Iggy Chua, so I did some of my clinical time with him. and he is able to see some patients through the Southern DHB, and I'll come back to that later, but he's the closest immunologist in the region. So, better start with, you'll probably be finding at the moment that the winter blues are sort of starting to dissipate, but so patients are feeling better in that way, but those with allergic rhinitis are starting to feel worse and succumb to the spring and the pollen that you see in the puddles at the moment. So just a bit of an overview of what I'll talk about. First of all, I want to talk about the prevalence of allergy because it is increasing significantly over recent decades. I'm going to talk about some of the theories behind that increased prevalence. There'll be a brief immunology lesson, but fortunately it won't be very detailed. And we're going to talk about some cases and then some take-home messages from those cases, and then I'll give you a rundown of what services are available locally. So I'm sure you all know this, but allergic diseases are of increasing prevalence. It now affects, in some shape or form, 30 or 40% of the world's population. So, and it's highest in urban areas and affluent areas, and lowest in areas in more poorer and rural areas such as Africa and Asia. And I'll come back to why that might be. Australia and New Zealand are among the highest countries with, some of the highest countries with the incidence of allergic disease. And a recent study in Melbourne, the Health Nuts study, which is very well cited, is they looked at 1-year-old children, and they took a massive number, several thousand, and they had a look at reported allergy, but they also had a look and challenged kids with oral food challenges. And they found that proven peanut allergy was present in nearly 3% of 1-year-olds in Australia, and nearly 9% had egg allergy proven. So that wasn't just parental report. So it is a big issue in this part of the world. This graph just demonstrates that really. It gives you, the top line is the 0 to 4-year-olds, and they're the individuals with most likely to have food allergy. So this is only in relation to food allergy. The lower, all these ones here are older people. So while there is food allergy there, it tends not to be as commonly associated with anaphylaxis and tends to be better managed, much less prevalent as well. So this is hospitalisations per 100,000 in relation to anaphylaxis related to a food. And you can see that over time, and this is a 10-year period, which is not that recent, the most recent being 2004, the incidence is increasing. And small numbers, but going from 3 or 4 in 100,000 up to sort of 17 in 100,000 is still significant in that period. And it's climbed again since then in the 15 years or 10 years, 13 years since then. This one just demonstrates the different types of allergy. You can see respiratory allergy appears to be declining, although when you look at the stats, allergic rhinitis has actually doubled in the last 10 years in Western countries. So skin allergies increasing and food allergies increasing, and this data obviously only goes back, still 6 or 7 years old now. So why is this important? Well, it's important because of something called the atopic march. A number of studies have shown that there's a developmental allergic march in children, and that from the onset of atopic dermatitis and food allergies in small children in infancy to asthma and allergic rhinoconjunctivitis later. And you can see that quite clearly. The peak in the food allergy is in the younger ages. Atopic dermatitis peaks quite young too, and then sort of tapers off more slowly. But asthma often will sort of reach a peak around school age years, and allergic rhinitis later on. So one thing that studies have shown is that sensitisation, which is not allergy, sensitisation just means being sensitised to an allergen. Allergy is actually being allergic to it, so having clinical symptoms of it. So there's a difference there, and we'll come back to that as well. But sensitisation to perennial aeroallergens, such as cat and dog dander, or house dust mite most commonly, happens mostly between the ages of 2 to 5 years. Whereas the seasonal inhalant allergens like pollens and grasses seems to be a bit later in life, so often in slightly older children. The earlier the onset of allergy and of asthma, the greater the severity, and the more likely it is that that disease will persist as well. So one thing that you might almost imagine from this, but has also been shown in research, particularly recently, is that if we can nip it in the bud somewhere down here, we can actually prevent some of those other allergies. So in particular, the move from asthma to allergic rhinitis, or from atopic eczema to allergic rhinitis, is something that we've got some control over, and we actually have the ability to make significant changes to the health outcome for kids in this sort of preschool and primary school age. So there's lots of new research going on there, which is great. So there's a few theories around why is this prevalence increasing, and you've probably all heard of these. The top one, I've put them in order of sort of importance, or the order that they're thought to be most important, I suppose, in the allergy world. The first one being the hygiene hypothesis. So you've probably all heard the theory that if you're exposed to less bugs, you're more likely to have allergy. And there's good evidence to support this. So there was one study presented at ASCIA which was thought was quite funny, and I can't remember the exact details of it, but basically they looked at a group of parents whose babies had been pacifier users, and the correlation between the food allergy of those pacifier users and how the parents sterilise the pacifiers. So some parents would sterilise it completely in Milton's or something like that. Other parents would, if it got dropped on the ground, would just run it under a tap, and other parents would just lick it and give it back to the child. And there was a correlation between less food allergy and the sucking of the dummy than those two groups. So that's only a correlation. Obviously there's lots of other factors to be involved, but there is some other research that points more towards that hygiene hypothesis. And the less in terms of bacteria and pathogens that we're exposed to at younger ages, the more likely we are for our immune system to sensitise to the wrong things and make a response to something that it shouldn't, which is what allergy is effectively. One of the things that this sort of demonstrates with the hygiene hypothesis is if you look at daily bathing habits by country, those that bathe the most, in other words, the ones at the top, and I'm sorry it's not very clear, I'll read it out, but have a similar graph to the prevalence of food allergy, and this is done through studies. So if you look at Colombia's right at the top, they like to be clean in Colombia, but they also have a high incidence, they're second from the top in terms of food allergy. And equally, and there's a couple of things there that aren't quite, UK's down here on this one and up here. I didn't realise people in the UK were so dirty, but anyway, it's very judgmental. But equally, you can see Turkey and China down here, and Turkey and China down here. So, less bathing may be associated with less food allergy. And this is just again, a correlation, but there are actual studies, which I won't go into the detail of, that help to support that hypothesis. The second hypothesis being food allergen exposure. So Gideon Lack did a lot of work in the recent years on looking at introducing allergenic foods to children with high risk of developing allergy, and found that those kids actually did better if they were introduced to those allergenic foods earlier. So gone is the thinking which was around when my kids were small, whereby you breastfed till 6 months. I think my son was 6 months and 1 day when he got to start solids, even though he was desperate for them earlier than that. He didn't start before 6 months. An atopic mother was a higher risk. You didn't give them possible allergenic foods until they were, at least 1. I didn't think of sending a peanut anywhere near them. And so what we probably now know is that we were doing harm with that advice. And the advice now has changed, and there's some new infant feeding guidelines, which I'll come back to as well. But clearly it does appear that the more tolerance that can be induced at a younger age for kids, the better. And then vitamin D insufficiency. So there is a school of thought as well. Vitamin D is the new wonder drug, isn't it? School of thought that vitamin D insufficiency is associated with increased food allergy. And there's some good studies to show correlation there at least. So watch the space with that one. But in reality, it's probably a combination of all of these things, and many more. So one of the things we learnt about in the course was not just the genetics and the genetic makeup that you have as to whether you're going to be atopic or not, but epigenetics, which is some fancy new thing that they didn't have at medical school when I was there, where the genetics can be changed, and Robin's looking at me like I'm totally talking a load of garbage, which is really scary because her husband knows more about this than half the world. Things like pollutants and the effect that they may have on altering genetics, maternal diet, the effect that that can have, viral or bacterial infections, both in the individual but also in pregnancy. The microbiome, that's the new thing, heard all about that last week. So they did these wonderful studies where they looked at infants and neonates and then infants, and they compared the microbiome. So basically they delved through all their nappies and figured out what bacteria they had growing in their gut and determined whether or not, whether there was a link between the diversity of bacteria, the amount of bacteria and the incidence of allergy. And it appeared that those who have the most diverse and the most numbers of bacteria in their gut had less allergy in general. So there's good evidence for that, and it's a rising trend. You'll hear more about poo sifting. And skin versus gut exposure. It's pretty well considered now that the lymphoid system of the skin and the gut work in slightly different ways, and that the skin associated lymphoid tissue is more likely to sensitise you, particularly when it comes to foods, and the gut is more likely to create tolerance. So that's where that whole lack hypothesis comes in, that probably you're better to be exposed to something through your gut and develop tolerance to it food-wise earlier than you are for it to be sensitised through the skin. So it's a whole lot of, anyway, it's fascinating stuff. And any of these things can have an impact at preconception, antenatal and postnatal periods of time. Tell me if I'm rabbiting on too much about immunology. So apparently immunology's really blowing up since we learnt about it. And so this is all I'm going to really say. Th1 and Th2, so T helper cells, you know, T cells, T lymphocytes. T helper cells, type 1, type 2, there's heaps of types, and T regulatory cells are kind of the main things that are involved here. Th2 cells, they stimulate B cells to produce immunoglobulin. And they're important for initiating, and so they're important for initiating an immune response to something foreign. Whereas Th1 cells are more involved in intracellular pathogens and the immune response to those. So the T regulatory cells, they help moderate everybody. They're kind of like the, moderators. And if a system is more Th2 active and Th1 or Treg is suppressed, then you're more likely to get inappropriate antibodies being made, and then the potential for IgE-mediated allergy. Now, I'm only talking about IgE-mediated allergy here, but of course there are lots of different types of allergy. And once again, at medical school, when Tim and I were there were 4 types, there's now 7. So just as well we didn't have to study that back in the day. IgE-mediated is type 1, so that's the one we most commonly talk about. And then type 4 is your contact dermatitis, and there are other types of immune-mediated response as well. I'm not even going to go there, that's just a pretty picture. So, patterns of allergy. It goes across lots of different systems, allergy. So you've got airways-related, allergic asthma, allergic rhinitis, and not all asthma or rhinitis will be allergic. So there's that sort of distinction to make too. Skin, atopic dermatitis, probably the one we most commonly think of, but urticaria and angioedema are also skin-related allergy, and not always IgE, in fact, very rarely IgE-mediated, but can be, so it gets a bit tricky there. The gut, there's eosinophilic esophagitis, there's FPIES or food protein-induced enterocolitis syndrome, and then proctocolitis, celiac disease. We've got our resident celiac expert in the room, yay. And systemic reactions or allergy is things like anaphylaxis to food, to venom, to drugs being the most common things that will cause anaphylaxis. So let's think about some cases now, because this is the more interesting stuff. So this is case XMAR. Okay, thanks. So this is a breastfed term baby who had eczema which started at 6 weeks of age, really scaly erythematous on the face, as it often is in neonates or wee babies, on the scalp, nappy area and chest. Mum was using, and I've highlighted the sort of things I want you to think about. Mum was using pawpaw and almond oil on the skin at home, which sounds all very natural and lovely, doesn't it? And the baby was treated with emollients and steroids and did get some improvement. I've put that little picture of mugu up there. Mugu is something that the Aussies use a lot of. It's a dairy-based, cow's milk-based product for skin. And it's great, but putting cow's milk, almond and pawpaw on the skin, when what I talked about before, skin being a sensitising organ, it's probably not a great idea if a child hasn't been exposed to it in the gut first. So that's the kind of one of the things to think about with this case. Now, Mum had excluded at the time that she saw us cow's milk protein from her diet, which seemed to help significantly with the child's skin. It cleared and it didn't require any ongoing steroids. So probably here there's an IgE-mediated cow's milk protein process going on with this child. I don't know that this mother hadn't used mugu, but there was a clinic practitioner I spoke to at Askia who had 85 babies who had used mugu and then developed sensitisation to cow's milk protein. And they did that by picking the subjects who had used the substance and then tested sensitisation, and a group who hadn't and tested sensitisation. So there was an association there. Not necessarily that those children all developed allergy, but they did develop sensitisation. So she had a skin prick test, which was positive to cow's milk protein as anticipated, but this is not always the case. So don't be fooled. It is more likely that there's a food allergen in small babies, but it's still not always the case, and the number one thing is manage the skin as you would for any atopic dermatitis. Another take-home point there is that I don't know why I put that point in blue, but anyway, the other maybe I do. Hang on a minute. No. So the other important thing about remembering about testing for allergy is it's only useful, skin prick tests and serum-specific IgE, or what we used to call RAS testing or EASE testing, is only important if you're looking at IgE-mediated allergy, and it's only going to tell you about sensitisation, not allergy. Okay, so that's a really key take-home point. One of the reasons why that's so key is that every time you order a RAS test, it costs $50 per allergen. So if you say, I want serum-specific IgE testing for 5 different things, there's $250. So you've really got to make sure that the allergens that you're testing for are clinically appropriate to be tested for. So these tests all of these tests, skin prick and serum-specific IgE, are useless unless there's a supporting history of allergy. In fact, often they can do more harm because we can then recommend that people avoid things that they're not actually allergic to, but they may become allergic to by avoiding them. So the negative predictive value of skin prick testing is 95%. So if you suspect, in this case, perhaps that X-Ma was allergic, had an IgE-mediated allergy to cow's milk protein, and the skin prick test had been negative, we'd say there's 95% chance that this is actually not an IgE-mediated reaction to cow's milk protein. Doesn't mean it's not to soy or something else, but and so that's actually a better negative predictive value than an ECG for MI. We all know they're a bit rubbish anyway. A CT for brain tumour, so it is quite good when it's a negative test. And never stop foods based on test results alone. So the clinical history really has to fit. Even in adults who avoid foods for 2 to 3 weeks, there's a high risk that they can become sensitised and then allergic to those foods. So that's been shown in adults, particularly with fish, shellfish and peanut, or tree nut, which is the more common adult food allergens. So, and also we heard at Askia a horrible story about a child whose mother had put, what's that guy's name? You know, the guy that's really popular with food, diet, clean living, kind of, Pete. That's him, Pete. So he had this book about broth. You make a broth for your baby. Yeah. So this baby was on this meat broth thing and stopped growing, ended up presenting to the hospital with a number of medical problems as a result of nutritional deficiencies. And this is scary stuff. I mean, it's probably rare that it's that bad, but all because the mother had felt that the child was allergic to so many different things. And whether or not, I don't know whether that child had had testing or not, but certainly if they had and then been told to stop various things, it was a problem. So can't emphasise enough how important it is to have a dietitian on board when you're talking about excluding things in kids' diets in particular, but anyone, adults as well. And I'd just like to say it's Dietitians Day today, so happy Dietitians Day, Josephine. And you can go to the Dietitians New Zealand website and find yourself a local dietitian. So and patients can do that too, and that's a useful place to know about. So back to ex-ma, solids started when she was 5 months old, according to the infant feeding guidelines, which are new, and I'll show you what they look like in a moment. She was weaned onto soy formula at 6 months, which is entirely appropriate. And the plan is for her to have a repeat cow's milk protein skin prick test, and to reintroduce cow's milk protein into her diet as soon as possible. And that can be done in a graduated way with the help of a dietitian usually. There is some talk about oral food immunotherapy, which is currently in research phases. So you will have heard of aeroallergen immunotherapy, but there are studies that are looking at gradually introducing the likes of peanut into diet to reduce the allergy and to induce tolerance. But they are in research phases, so if you've got someone coming in asking for that, it's not something that's on offer at the moment, and it is a bit, the jury was completely split at Askia, so some of the specialists were all for it and some of them were, oh geez, I don't know, that makes me nervous. There's a study recently in Melbourne which has looked at the introduction of peanut and probiotic together, and it seems that there's an increasing ability to gain tolerance if probiotics are used as opposed to just introducing peanut on its own. So there, again, the microbiome comes into play. So it may be something else to watch this space for. If you're interested in the infant feeding guidelines, which, as I said before, have changed remarkably how we think about things, and really only in the last year. This only came out last year. Everything you ever wanted to know about allergy is on the Askia website. And that's the website address there, and including these guidelines. So these basically say introduce from the age of between 4 to 6 months, when your child is appearing to be interested in foods, infant appropriate food choices, so you don't give an infant a whole peanut, but infant appropriate food choices with a variety of foods, aiming to have every food that your family would normally ingest in their diet introduced by the age of 12 months. And that includes infants who are at risk of high risk of allergy, so those who have had terrible atopic dermatitis or a strong family history of atopy. Excuse me, and includes the highly allergenic foods. So you don't need to stay away from those or avoid those or introduce them last. Obviously you tend to start with bland foods and things like that. And it used to be said that using partially hydrolyzed infant formulas was maybe a protective factor. There's no evidence for that anymore. So they're now saying don't bother, go straight on to cow's milk protein based formulas if a child's not being breastfed. So is there any questions about that case, ex-ma? Sorry, it took me ages to come up with that. Yeah.
Can I ask about the age of infants where you should maybe think about doing the skin prick testing for the first time?
Yep. So it's quite appropriate to do it at any age. You'd be pretty really doing it below the age of sort of 1 or 2 months of age, because most infants at that stage won't have demonstrated much in the way of IgE-mediated allergy, and if they have, if they've got eczema at that age, you're probably still going to be in the process of trying all the emollients and steroid treatment and things like that first before you go down the food allergy pathway. But yet, from any age, the lab only offer skin prick testing for over 2s in Dunedin. So, but I will be offering food-based skin prick testing for under 2s. So the next case is pterynismus. Thanks, Kristen. Who knows what pterynius is? No, it's a house dust mite, the most common European house dust mite, as opposed. So yeah. So anyway, that's a bit geeky, but so Terry is an 8-year-old male, and he has a history of 17 months of constant and increasing symptoms of allergic rhinitis and conjunctivitis, including itchy throat, ears and eyes, sneezing, clear coryza, and nasal congestion. He doesn't get any seasonal variation over that 17 months. And he's got 2 cats and 1 dog, of which have lived in his house for 6 years. So he didn't have symptoms until 17 months ago. He's got a history of atopic eczema, and he always gets a wheeze when he has a viral urge. So, you know, there's millions of kids like this, right? He also has a family history of atopy. So his mum has asthma and his dad has allergic rhinitis. So he went on and had some skin prick testing done, and he was positive to cat and to house dust mite, and he was negative to dog. So they killed the cat. No, I'm just joking. So probably the cat is not the issue, actually. Probably the cat's fine because he didn't have symptoms with the cat until recently, but it might be something to do with it. So you might talk about the cat and finding a new home or something like that for the cat. But the dust mite is probably the bigger issue. House dust mite allergy and sensitisation is extremely common, especially here. And so there are dust mite measures that you can use. So there's covers for your mattress and your pillowcases, and if you want to spend thousands of dollars, there's heaps of those sorts of things that you can use. And they do provide some benefit, but there's a lot of maintenance and care required with them. So you've got to wash them every week and wash them in hot water. You've got to dry, or you've got to do all your washing and dry it all in the dry. You know, stuff like that. That's sort of, you know, you can get quite pedantic about it, and you still can't get rid of dust mites because they're everywhere. Okay. So the other thing that was recommended for him was a saline nasal rinse. So just to help flush the sinuses and the nose of the irritant, the aeroallergen in the environment, in his sinuses. Intranasal corticosteroids I've put in red because they're the key, really. You know, you're still going to start with this, whether it's allergic-based rhinitis or whether it's a chronic rhinitis for another reason. And they're excellent. And he's 8, so he's probably going to cope with intranasal corticosteroids pretty well. And then you might consider for him, if he wasn't getting a lot of benefit or relief with this process, and you might also be using some antihistamines, you might consider immunotherapy. So there's 2 sort of main types of immunotherapy. There's subcutaneous and there's sublingual, and some of you will be delivering subcutaneous immunotherapy already. It usually gets initiated in secondary care or in immunology clinics because of the risk of anaphylaxis with subcutaneous immunotherapy, even to aeroallergens. And then it can be continued in primary care. There's always a risk if patients go for a long period or a period of time where they haven't had their immunotherapy that they can develop a more severe reaction to it when they restart. So that's something to be aware of as well. The sublingual immunotherapy is also available. Both of these are available for house dust mite. There's a couple of different ways of getting sublingual immunotherapy. One is drops, one's a spray, and another one's a tablet. And the Acdea, which is the tablet, is just recently, in the last couple of months, become licensed in New Zealand for use. So that's something that can be started. The first dose needs to be given at least in primary care and with supervision. There's a tiny risk of anaphylaxis with that, and then the rest of it can be given at home. Sublingual is given on a daily basis, so it's a commitment from patients, and it's a cost commitment as well for either of those 2 options. Round about a couple of $100 a quarter at least, so is the cost of those treatments. There was really good stuff, and we heard a lot about this again at ASCIA, the Melbourne thunderstorm on the 21st of November last year. And it's not the first one of its kind. Melbourne's quite famous for these, it seems, but that was probably the worst. It affected over 20,000 people over the course of a couple of days. And it's related to the thunderstorm, the atmospheric pressure, all splitting the pollen particles and making them even more easily ingested, more easily allergenic. And so what they found was that there were 2,000 calls to the ambulance in 5 hours, and there were 9 deaths. And they were all directly related to pollen allergy in patients with mostly allergic rhinitis and some with asthma. So 80% of those people with asthma will have allergic rhinitis, And if you don't control the allergic rhinitis, you'll never get on top of the asthma. So just remember that it's a united airway. Ear is nose and chest. Only about 40 to 60% of those with allergic rhinitis will have asthma, so it doesn't actually work necessarily in reverse. So Fleetwood Mac, yep. And so then, thought that was quite good. Don't know. It's probably happening in affluent urban areas. So now there's another case of anaphylaxis. Oh, sorry. Was there any questions about Terry?
So where do you actually get the desensitization things from? I haven't had any patients asking me about it.
No. They can get it on prescription. Yeah. And anyone can prescribe it. I think it's a significant expense to the patients. I think it's really important to make sure that it is something that's going to be of benefit to them, and that it's done in a safe way, particularly subcutaneous, but sublingual as well. And I must admit, I thought I knew a bit about these things until I learnt a bit about them. All of a sudden I was like, oh, right.
Anna, I remember seeing something about freezing your pillow or throwing your pillow out regularly because a scary proportion of the weight of it becomes house dust mite feces after a while.
Absolutely, you are literally sleeping in shit. It's true that freezing it will work. It only gives you probably a few hours, if that, of relief. So if you're going to freeze a pillow, and soft toys this works for too, put them in the freezer. If you've got a chest freezer, that's fine. If you've actually got food in your fridge freezer, it's probably not going to fit. But you put them in there, put them in over the course of the day while the kids are at school, whip them out at bedtime. Kid sleeps on a cold pillow with a cold soft toy, but less likely to get irritated by the dust mites. So it settles down the dust mites, doesn't actually get rid of the faeces material or the skin particles or anything like that. You're probably better to get really thick, non-permeable, good quality house dust mite covers, wash them every day, for pillows, that is, in hot water.
Every day.
That's what they say for pillows, yeah. So it's intense. And you're still never going to get rid of all those bloomin' dust mites.
Does the hot water actually work? Because I thought the microbiologist said, it comes out at 55 degrees of the tap and then it hits the Dunedin metal.
Yeah,
and it's not actually hot enough.
Well, that's a good point. I don't know the answer to that. My understanding is using the hot water is going to be helpful to some extent, I guess more so than cold water. But you're right, that's mostly, my lecturers were mostly Australians, so they probably don't really know what we deal with here in Dunedin. So it might not be quite good enough.
Fancy vacuum cleaners with HEPA filters and all that? Is there are they worthwhile?
Yes, they are. So there is good evidence that actually they do help to contain dust mite. But once again, you're still never going to get rid of it. And we can't tell people in Dunedin to rip up all their carpets, and even if they do, it's not going to probably be all that beneficial for the cost-benefit ratio. Yeah. So anaphylaxis is a 35-year-old female with a history of asthma, and she's taking no regular medications except naproxen for period pains. And she presented to ED with an anaphylactic reaction after ingesting prawns at a dance party. So she'd eaten prawns once or twice before without problems. So what are the possible cofactors? You guys know about anaphylaxis, so I'm not going to dwell too much on this, but what are the possible cofactors that could have led to anaphylaxis in this instance?
An NSAID or the NSAID could
Yep,
be part of it.
absolutely. Anti-inflammatories, commonly known to increase your risk or increase your severity of an anaphylactic reaction. Yep. Dancing, exercise. So exercise increases your risk. What else?
Did she take some drugs at the dance party?
Oh, probably. But apart from the anti-inflammatories, they were quite safe. Yeah. Sudafed.
A long period between eating prawns?
Possibly, because she may have developed some sensitisation there. Yeah, possibly. It may be that she actually had an IgE-mediated reaction to prawns even back then, but didn't have all the other cofactors. Yeah.
Does her history of asthma tell you that she's already a sort of allergic type person?
Absolutely, and the degree of control of her asthma is really important. So if she's not got good control of her asthma, the chance of her having a more significant anaphylactic reaction is, of course, much, much greater. So really important when you're seeing your asthmatics to drum into them the importance of having, particularly if they've got allergy as well, or anaphylactic history, the importance of controlling that asthma. What else?
Is alcohol a factor?
Absolutely. Alcohol lowers your threshold, is the word I was looking for anaphylaxis as well. Yep. Well done, Ian. And one more thing.
Is there sex have an effect on it?
No, I'm not sure that gender does make a difference actually, but menstruation does. So in that regard, if she's menstruating at that time of the month, certain hormonal things will be triggers as well. So she's
Do you
at
mean
high
the
risk.
gender or having sex at the dance party?
I'm going to leave that to everybody's imagination, actually.
Okay.
So
Knowing
the
David,
gender doesn't care because the blokes don't have menstruation, so gender doesn't.
it does, yeah. And having sex at the dance party is exercise. So that's making a big assumption. It might not be, but anyway. So those are the cofactors. And she may also have had a cold. Having an URTI, an upper respiratory tract infection, will increase your risk of a more significant anaphylaxis as well. So EpiPens are the only available adrenaline that we have in New Zealand in an instant, easy-to-use form. And you should all know how to use one. Didn't bring one with me because I forgot, and I've got dozens now. But they're really simple to use. If you remember, blue to the sky, orange to the thigh, take the blue cap off, jam it into the thigh and hold it there for 3 seconds is all you need to do. So they're really simple to use. They are, however, expensive in New Zealand. The cheapest you can get them for is $120 through the Allergy pharmacy, which is based in Queenstown. And they deliver for free, so that's the cheapest you can get them for. They have a shelf life of about a year only, so they expire quite quickly. So people are often having to spend a lot of money. There is, and I've got for you, and you might like to just pass this around, some new stuff on ACC. So ACC will fund a EpiPen if it's being used in the appropriate circumstances for an anaphylactic reaction, and if the patient has an allergy, an anaphylaxis action plan, and if they have the receipt for the EpiPen from when they bought it. So they'll wiggle out of it any way they can, but you can get funding, you can actually get some cover for these accidental allergic reactions. And obviously, so the other things to think about with her is that she was given adrenaline at the time, of course. She will need to have an EpiPen prescription. You don't need a prescription, you can just buy them online yourself without one. She should have an anaphylaxis action plan. Anyone who's had anything that sounds like anaphylaxis should have an action plan. And she should probably see an allergist, or at least her GP, for follow-up and how she's managing this. And often there'll be a lot of anxiety, as you can imagine, around these sorts of things. It may be appropriate, depending on what the anaphylactic reaction has been thought to have been triggered by, to do skin prick testing or serum-specific IgE as well. And obviously managing her asthma is really important, and discussing with her the possible cofactors. So that she knows the situation where she might be at higher risk down the track. Excuse me. This is an anaphylaxis action plan. They're easy to print out off the Askia website. This is an individual one, so there's also a poster version that you can get that's more generic. You can put in the patient's details down here, including their next of kin details and things, and what you think their allergens are. It can be signed by a doctor and reviewed every year or so is ideal. How to give an EpiPen is demonstrated down here, and what to do in the event of an anaphylaxis. And I'd just like to point out this. Lie a patient flat or sit them up. Never stand somebody who you think has anaphylaxis. And even sitting up can be quite dangerous. Apparently more people die from the hypotensive effects of anaphylaxis than they do from airway closure. And it's because we make the mistake of standing people. And probably it's one situation we've got to be careful about. But there's all sorts of things there, including the red flags that patients need to look for and their carers. So that's a really useful thing to know about. This is... once again, this is the Askia website. Oh, there you go, Society of Clinical Immunology and Allergy. And that was the most recent conference, but they have one a year, usually in Australia. So the sort of take-home messages from all of those cases, or from the presentation really, is that allergy's on the rise, clearly. Don't use food-based products on eczematous skin, would be my advice. Skin prick testing and serum-specific IgE testing is an indication of sensitisation, not allergy. Remember the infant feeding guidelines and always include a dietitian, and we're going to hear from Josephine shortly. Immunotherapy may stall the atopic march and may be beneficial in quality of life, particularly for things like allergic rhinitis and asthma. EpiPens and action plans, don't forget about the two together always, and the ASCARE website is a useful place for more information if you'd like to get it. Is there any questions about the last case? So I'm just going to tell you now about allergy services in Dunedin. So we, as I said earlier, we have no local immunologists. If you have a patient who's had a venom anaphylaxis, so bee or wasp, then you can refer them to the general medicine department, who will send the patient an appointment several months later. They'll see that person and then they will refer to the clinical immunologist in Christchurch. I'm hoping to bypass that pathway because that's ridiculous waste of resources, in my view. But currently that's the pathway, and no one's very keen on changing it. So, and they will then eventually get an appointment to see Iggy Chua in Christchurch, and will be offered venom immunotherapy in Christchurch, which needs to be done in a hospital setting anyway. So that's the immunology side of things. In terms of public options, obviously dermatology, ENT, respiratory and peds, and Kalhari, who gave a presentation maybe this time last year, I can't remember now. She has taken over the allergy sort of special interest in paediatrics from where Pam Jackson left off. So all of those fields of expertise have some knowledge across them of allergy. And it's a little bit variable as to who you strike, as to what their knowledge is and things, but obviously it crosses over all of those. Private options, there is Pam Jackson, who is still working at Maranoto a couple of days a week, I think. She does see adults and children, and I understand she is something like $300 an appointment. I'm not certain about that.
What's the SI stand? Oh,
special interest. Paediatrician with a special interest. Yeah, so she's not an immunologist. Dietitians with special interest in allergy would be Nutrition and Life, which is Josephine. She's going to be talking to you in a moment. Jumpstart Nutrition, Jennifer Douglas, who works out of the Meridian Medical Centre, and Angie Lucas, who's developing her interest in allergy, and she does one clinic a month with us at Musselburgh Medical Centre. So they're the ones I know of. There's probably more. And then there's me, and I'm hoping that you might have some people you'd like to refer to me, because if there is a gap, I'd be very keen to help fill that in the community. So I will be accepting, as of next week, either self-referrals or GP referrals. The ERMS referral option is coming, but in the meantime, there's a fax number that I'll give you that you are welcome to fax referrals to. I'll be seeing patients on a Wednesday afternoon, and I'll only be seeing a few a week, but to begin with, see what the need is. It'll be $250 for a 45-minute appointment, which does include a summary letter that goes to the GP and the patient. Health insurers are slow in their processes, but it's likely, because of our need in services and from the homework that I've done around the country, that there will be, that health insurers will probably cover my consultations. But we just have to get that confirmed. So it's not there yet, as far as I'm aware. Some of them have pretty dubious processes. Skin prick testing I'll be providing on site and will be included in the cost for children under 2 for food allergy things, and for some adults for food allergy too. But the aeroallergens and things I'll be requesting from the lab, because they have as good a range as I can get anyway, and they're extremely expensive. They're about $70 for 2.5 mils of allergen, so they're not cheap. And I'll be offering immunotherapy as well if it's indicated for those who it's most appropriate for. So that's my email address, our phone number at Musselburgh, and our fax number if you would like to do referrals. And I have some little flyers if you want to take one and remind yourself of my service. So thank you for listening. And your one. There. Thank you. Lovely. There you go. Oh, now you need this. doing it somewhere. And you might be able to put that on instead, actually. If you don't want to hold it. So Josephine Greer from Nutrition and Health. Nutrition and Life, sorry.
Thank you. Hi, I'm Josephine. As you know from Nutrition and Life, we're based at Suite 7 Marinoto Clinic. And I mainly see the adult population. So today I thought it'd be nice to have a small section on food allergy versus food intolerances, because mainly what I see coming through the door is food intolerances with a few food allergies scattered in the mix. And today, as Anna said, is National Dietitian's Day. First time it's been on September the 19th, so I thought I had to put that in there since it happened to be today. And most of the dietitians in town are at a potluck dinner tonight, so yeah, I'll be joining them soon. So, as Anna said, there's a few paediatric allergy dietitians in Dunedin, mainly Angie Lucas and Jennifer Douglas. Sophie Nation also has done a little bit of work in the past, but not currently. She's mainly doing ACC work, so if allergies is available through ACC, she may be a good option in the future. And the Nutrition and Life, we're providing adult dietetic input. So today I want to touch on food allergy versus food intolerance in the adult population, testing for food intolerances, which is quite non-existent, and comparing that to testing for food allergy, nutritional implications of both allergy and intolerances for people who are restricting things in their diet, and then what we can offer to support those clients. So the blanket term we use for allergies and intolerances in a dietetic clinic is adverse food reactions to food, or adverse food reactions, and that's because it can be quite tricky when you first see a patient to know whether they're having an immune mediated or a non-immune mediated reaction to food. We know that the reactions to food allergies are life-threatening, but intolerances, it's very unlikely for those reactions to be life-threatening. But often it is really quite phasey where we're sitting. So with our food allergies sitting here, lots of those ones that Anna talked about for your fish, peanut, soy, dairy and wheat. Whoopsies, there we go. Then we've got your mixed IgE and non-IgE mediated forms of allergy, food allergies, and then also cell mediated. So FPIES, which food protein induced enterocolitis syndrome, which has got a lot of attention in the media recently, which is an allergy, non-IgE allergy to, and you can have multiple triggers. So the children who are presenting with these is quite severe, isn't it, with up to 10 food allergies, often to fruits and vegetables, and need immediate medical attention and quite hard to manage for the paediatric dietitians. And then of course we have celiac disease as well. So our food intolerances, in contrast, are not immune mediated, but we have quite a range of things which can cause intolerances, and we want to know what's behind any food reactions. So firstly, you can think of things like stimulant foods, like coffee is a food reaction, as well as tyramine foods for things like headaches as a food intolerance. Also enzyme deficiencies, so lactase intolerance is really common, one that we see with the FODMAP group of patients, and after gut inflammation as well, so it can be transient. Also, multiple other enzymes. If someone's had pancreatic surgery, they'll have enzyme deficiencies which could cause food intolerances, as well as all sorts of enzymes like diamine oxidase, which is related to histamine breakdown. So we do start to think about histamine in some of our IBS patients a little bit as well. Of course, if you've got gallbladder removal or bariatric surgery, you can have food intolerances develop at the level of the gut as well. Food toxicity, if someone's had episode of gastroenteritis, we might have food intolerances after that event that can be managed with some adaptations to the diet. And we also can't rule out a psychological effect of food intolerances. So often there can be psychological triggers or preconditioning or expectations around certain foods that are going to cause reactions, which play a big role, especially after we've put patients on elimination diets. So we have to be quite careful what we're ruling out when. And the big one, of course, is FODMAPs. So you'll all be familiar with FODMAPs and breath testing and small intestinal bacterial overgrowth, or SIBO, which is a cause of food intolerance sitting alongside IBS, where the patients can also have an adverse food reaction to carbohydrates that sit outside your fermentable carbohydrates, or FODMAPs. So they're having a bigger range of foods which we might have to cut back for a temporary amount of time. Testing is really difficult in food intolerances. It's not like allergy, where we've got your skin prick tests or your blood tests, which are reliable enough to be useful. Intolerances, the only way to do it is by diet exclusion and re-challenge. So you want to be doing that with a dietitian to make sure that people aren't over-eliminating foods. Blood tests can be really useful to test for underlying causes, of course, so celiac disease, IBD, checking that what else is happening to cause the food intolerances, but you can't test your blood for actual food intolerances. Breath tests we use for small intestinal bacterial overgrowth now, not so much fructose lactose like we were 2 years ago, because there's been some new research to come out which says it's questionable for testing for lactose and fructose intolerance. So again, much better to eliminate it from the diet and put it back in. And if we use breath tests, you'd have to do the food eliminations alongside that for any reliable results. And then multiple other tests for intolerances, but the evidence really isn't there. So skin prick tests are not an effective way to do things. Hair tests, iridology, or kinesiology, even more so. Lots of patients come to us with these tests. I'm sure you see them too, but unfortunately no use for us with food intolerances. So there's the food implications of food allergy or food intolerance are the same, but with food allergy, we generally find people are cutting out, if you cut out fish or soy or nuts, there's less of an effect on nutritional adequacy. With food intolerance, people are much more likely to be self-eliminating foods without guidance from their doctor or dietitian. So that's actually where there's more nutritional risk for the client group I see anyway. So if we look at things like milk allergy, the risk there, of course, is that we are concerned about calcium intake and protein intake, especially in children. When you're removing wheat, rye, oats or fructans, with our wheat allergies or celiacs or fructan intolerance for FODMAPs, we start to carefully monitor B vitamins, fibre and certain minerals, folate. For salicylates, which is found in a lot of fruits and vegetables, it's becoming more popular to eliminate salicylates, and then because you're cutting out such a wide range of fruits and vegetables, we'd be carefully monitoring again vitamins, minerals and their fibre intake. And FODMAPs, again, fibre is the big one that we're concerned about, but also if they're eliminating lactose, we've got to be careful for calcium and vitamins and minerals as well, because you do eliminate some fruits and vegetables with the FODMAP diet. And long term, we do worry about the microbiome. The buzzword at the moment, if we're cutting out fermentable fibres, and we're shifting that bacterial population, what's that effect long term? So we want people to be reintroducing FODMAPs within 6 to 10 weeks of going on the FODMAP diet, and we don't want them to do that long term. So what we're wanting is close medical and dietetic supervision for patients suffering not just from food allergies but food intolerances as well, to reduce the risk of nutrient deficiencies, help people to choose the most appropriate choices within their social, financial limitations, and reduce the burden of stress, because there is a huge quality of life effect of people with food intolerance, as you will know. So what we can do in clinics is assist with assessment of potential food allergies or intolerances, assess nutrient variety and completeness, make sure that appropriate food exclusion advice is given, monitor for timely food challenges, so making sure for intolerances that we are re-challenging and getting the diet to be as varied as possible, and then give up-to-date evidence-based best nutrition practice, and that generally is putting a lot of those foods back in to long-term.
So how many of the FODMAPs people are better after 8 weeks? And what happens?
Most people, the studies show about 85%, but with those remaining patients, I'd say you could be looking at another form of intolerance, or looking at stress effects on the gut, or it's not that the FODMAP hasn't worked at all, it's just that we haven't got the full resolution, or it's the wrong diet for the person.
So why can they tolerate it again afterwards?
That's a really good question. We think, but the research is a bit tricky. Actually, Michael Schultz's PhD student recently did a study, and they tried to look at the microbiome shifts to show that what we predict, the hypothesis is, when you take out those FODMAPs, you're shifting the microbiome, and then when you put foods back in, you've got a different population of bacteria that you're helping, or you're bolstering back up. But of course that's very hard to prove. And they did have a hypothesis recently over in Canada with Michael Schultz's PhD students to test it, and Monash is also doing all these tests, but unfortunately for this recent study that I've heard a lot about, the power was lost to the freezer with all the stool samples before they processed their results, and it was looking really promising. So yeah, a big shame, and yeah, there needs to be a lot more work done. But even if patients don't tolerate it when you first put it back in, I'd be encouraging them to do it in 3 months' time, come back and do another challenge 6 months' time, and people do liberate their diets over time, absolutely, yeah.
What's your advice for constipation? If someone's doing the low FODMAPs diet and for whatever reason they're now constipated, you don't want to add in fibre unless it's, so what do you advise?
Absolutely. There's lots of fibres that aren't fermentable. So things, and it's also taking smaller bits of different things. So things like oats, they can have a quarter of a cup on the FODMAP diet. So lots of my patients would be on things like oats, linseeds, even carrot isn't fermentable, but it has got plenty of soluble fibre. The fruits that they can have, we still want them to be having a really high fruit and vegetable diet, even though they're cutting out some. So yeah, it's just working with the diet to up fibre, even though we've cut out FODMAPs. You've still got your starches, you've still got some cellulose, and a range of different soluble fibres as well that we can use. But constipation predominant IBS is much trickier with FODMAPs than your diarrhea predominant. It's generally slower to see improvements, and constipation in the elderly is another one which is really tricky, and it is slowly introducing your fibre up for those patients. Even things like Metamucil, I start really small and slowly increase. And for constipation as well, for the elderly population, I often use walking in the morning to try and get that physical stimulation as well. But it is tricky, the constipation ones, I agree.
So if there's if you do the FODMAPs thing and there's a change in the biome and clinical improvement, is that a permanent shift, or I mean, what would the sort of figures be? Does some regress to their symptoms, or if I guess what I'm asking is, if it works, is that it, or do they tend to get?
It's not it. No, it tends, well, for post-infectious IBS, it's it. Usually I do over and done with 12 weeks of the FODMAP diet, and they're much better. Longer term on the FODMAP diet, but generally pretty good for a while actually. But your IBS patients, no. We want them to be having a really high, actually a high fermentable fibre diet after that. So some onions, some gluten, some of all those things that are going to keep their gut microbes healthy. And if they're doing that, it should remain. But if they switched over to a highly processed food diet, generally we'd see those symptoms coming back. So they do have to look after their guts to keep it sustained. Also, if there's a period of stress in their life, likely that it's going to come back too. Yeah.
So you might need repeat treatments.
Yeah, absolutely. So once they've learnt the FODMAP diet, I'd be encouraging them to go back on it if they need to for periods of time. For women, sometimes it's just premenstrually, especially in endometriosis, because the bloating just comes on obviously premenstrually. And for things like students, it's before exams, use your FODMAPs. Or for anyone who goes through a big life event, I set them up to expect that they will need to use that FODMAP, and it's a tool that they will use for short periods on an ongoing basis. Yeah. Yeah, they won't need to do their challenges as strictly again. They'll know pretty well what are their main food intolerances, but yeah, it is useful. Yeah, so thank you, that's us. You can find us at Suite 7, and there are lots of fantastic dietitians in Dunedin who are all celebrating dietitians today, who you can also refer to. Down the back.
It's available in the public sector.
The FODMAP diet is available in the public sector. The follow-up, I think, is often, it might not be that the follow-up is fast enough to push them through the diet. So sometimes people prefer to go private. We've just started a clinic in Balclutha actually, because the follow-up wasn't quick enough to push people through the diet, and they ended up being on it a bit too long, or not completing the diet. Yeah. But it is available in the public sector. There is also some private insurance coverage for dietetic input privately. I don't know if you're aware of it, but Southern Cross pays up to $680 a year for private dietetic input, and most private dietitians are $130 to $140 an hour, so that's enough to get people through an elimination diet. And more so, ACC is funding dietetic input as well for anyone on a training for independence program, a pain contract, a sensitive claim contract, and some vocational contracts. So you'll definitely see more patients able to access dietitians through ACC, and you can make that referral through any of the rehab providers like Southern Rehab, Advantage South, APM. They'll all have dietitians on their teams now. Thank you.
Thank you so much. Now that we've heard from both of you, are there any more questions or discussion to be had? Shall we? Do you want to?
Yeah.
Maybe.
Anna, what
If we can fit both of you in.
Oh, right, okay.
Video. I've heard quite a lot recently about caesarean births versus vaginal births and vaginal seeding.
Yep, really interesting stuff, again related to the microbiome. So there was a study that looked at the maternal fecal bacterial variability. Again, hopefully the fridges worked that time. And again looking at the probable relationship with the infant or neonate fecal variation and the incidence of allergy. And I just think this is going to be a massively growing area, particularly in relation to food allergy.
Because there were some people saying if you have a caesarean birth, you should swab the mother's vagina.
Correct.
And put it all over
Yeah.
the baby.
Yeah, and there really isn't enough evidence to go smearing babies in poo, but it may be that there is at some point. Yeah, it's looking that that's a possibility, but hopefully it's not a done thing just yet. Yeah. So, Dad, would you like to do the poo smear or cut the umbilical cord? Yeah. Yeah.
What explanation is there for people that you sometimes see who seem to have episodes of acute urticaria intermittently, but for no obvious common factor?
Yeah, that's a really good question, Janet. And I've discovered that urticaria is almost always not IgE mediated and very difficult to pinpoint what the cause is. So chronic spontaneous, chronic inducible urticaria. Inducible means, you can find out what the cause is, and it might be cold, it might be water, it might be pressure, but the chronic spontaneous urticaria is really difficult. We've got a patient at the moment who I've referred to Igi Tua in Christchurch, and she hasn't seen him yet. In the meantime, it's probably going to burn itself out, as these processes seem to do, particularly in children. But it's very debilitating. The best medication for it is something called omalizumab, which we don't have in New Zealand. Well, we do, but only for severe asthma and only prescribed by a specialist. So we don't have it for the purposes of urticaria, but it's the only thing that really works.
I was thinking more of the random things that just like weeks or months apart, there might be an episode of urticaria with
no apparent
common factor in the
Yeah, so I guess if you can't find a trigger, which you mostly can't, those are the acute spontaneous urticarias, and they're probably managed a whole lot better with regular use of antihistamines. So for some people, we've got a patient who has heat-induced or sunlight-induced, most likely, urticaria, which she mostly only gets on her feet. And she, right through the summer, so from about this point in the year, she starts her antihistamines anywhere up to 4 times a day, but starts with once or twice daily, and just remembers to use them every day, and it keeps it at bay. And so for some people, using daily antihistamine is a pretty safe thing. It's a pretty safe medication. So. Yeah, there's less evidence for that now. In fact, the guidelines now are saying ranitidine probably doesn't have an added benefit, but I do sometimes add it in just because occasionally it seems to make a difference, and when you're clutching at straws and you want to try the next thing, then you might add it in. You might add in leukotriene receptor antagonists as well. For some people, they have a benefit, and short courses of steroids, if they're needed, will be helpful, but obviously we want to leave them till the last resort, really.
And would something like the episodic urticaria, would that ever turn into an anaphylaxis?
Very, very rarely. So if you have urticaria and angioedema, and therefore it's affecting areas particularly that are related to your airways, then you could have an airway problem acutely, but not really, unless it's an IgE-mediated process. Anaphylaxis is always IgE-mediated. So most of those urticarias are not. They're bradykinin-mediated processes, so slightly different. Yeah.
With the sort of microbiome theory, what's the thinking about antibiotic use in children, and have they found a link between early antibiotic use and allergy?
Don't know. That's a real big don't know at the moment. They started to talk about that at conference and things. My understanding is at this stage there's not really any great evidence that probiotics are going to be beneficial to recommend for everybody with antibiotics. Even our own pharmacist next door yesterday offered me probiotics with my antibiotics, and I said no thanks, I'm good. Probably it may have more of a role in kids than it does in adults, and it's very likely that probiotics and prebiotics, which are coming into infant formula preparations, may have a role in altering the microbiome of infants. So, sorry, that's not a good answer.
Or maybe we have to stop giving kids antibiotics.
Yeah, well, certainly when we shouldn't, when they're not indicated. Yeah.
Is that sort of highly developed countries that have a problem?
Yeah, it's one of the possible associated factors, definitely, and particularly the more they look at the microbiome, the more that's a possible factor.
And I'm probably going to embarrass myself asking this question. I was probably asleep or something, but I think you said you'd explain the difference between sensitisation and allergy. Did I just miss that? Or?
So I might not have explained it very well, actually, Peter, but sensitisation indicates that your body produces an IgE antibody to something that it shouldn't, an allergen.
Without symptoms?
Without necessarily symptoms.
Okay.
So if you have an IgE-mediated allergy, you will be sensitised to that allergen, but you can be sensitised without having clinical features of an allergy.
So you can have one without the other, but not the other way around.
You can have sensitisation without allergy, but not IgE-mediated allergy without sensitisation.
Thanks.
Yeah.
So what's the current position on oral steroids, even in short course, for your miserable allergic rhinitis sufferers?
Short course oral steroids is reasonable if you're looking at anti-inflammatory effect on the sinuses and the nose. There is no evidence that the benefits outweigh the risks for IM steroid for allergic rhinitis. And usually it's a last resort short course of oral steroids just to get the inflammation settled. And it's not uncommon that, particularly at this time of the year, we see people who have had colds for 3 months, and actually they've got a chronic rhinosinusitis. They may have a degree of allergy in that, so they may be people who they're sneezing a lot and they find that their symptoms are worse first thing in the morning because they're sleeping on their house dust mite poo infested pillows all night long, but actually they don't have those symptoms the rest of the year when their sinusitis is cleared. So if you can clear that out, if you can refer them to ENT if the topical oral intranasal steroids or prednisone are not working, they may need some surgery, that sort of thing. And if the symptoms go away, they don't need desensitisation to anything. Yeah, so it is worthy.
So the people who come in and say, I want my injection for my allergies, it's quite reasonable to say no?
Big no-no, yeah, particularly amongst the immunologists. Big no-no. They say absolutely not, never. It works. It works. But the risks outweigh the benefits. There are better treatments for allergic rhinitis that don't carry the risks.
Adrenal suppression, isn't it? That was quite, but I've never known whether that's more theoretical than real. Because the people who really want
the risk being
rare,
adrenal suppression, you mean?
Yeah,
and I guess, and all the nasties that steroids can give. I don't know. I mean, that's their take on it. I imagine it must be really difficult if you've got patients who have benefited from it every season.
Because my experience has been they're very few and far between, but the people who really want it.
Yeah. Tanya.
Patch testing, do you offer that?
Oh, no, I don't, because I think that's more of a dermatology field. So that's contact, it is a good form of testing, and in relation to contact dermatitis, and it's a type 4 hypersensitivity. I think the dermatologists are really good at that. So I don't offer that, and it is a different type of allergy than what I've learnt about. Patch testing. So for things like nickel and hair dye, and there's lots of good things you can test for, and I know that the dermatologists offer it, but yeah, no, not me.
Right. I remember reading a few years ago an article by someone in Auckland saying these patients with complicated allergy must be referred to an allergy specialist. Of course, we don't have that expertise here, or we didn't. So now we've got it. We're developing it. So that's really fantastic. So thanks. It opens up whole new avenues of options, I guess. So thanks so much to both of you for coming along and telling us all about it.